And what did I do? Where did it go? PowerPoint there? No, of course not. It's hiding somewhere. Oh, there we are. I'm hoping. No, not there. I have to go after it again. Come on, open up. Please. It's so annoying. Save. There it is. Okay. So under the individual psychological and cultural issues around medications, let's go to slideshow. Just some of the things to bring into consideration is some of the sort of the underlying holistic approaches to pharmacotherapy and the individual human integration of the pyramid model, the psychosocial and spiritual factors, and then look at the ethnicity and pharmacotherapy outcomes, as well as value, belief, and practice influences, as well as community. The genetic and polymorphism that can influence pharmacotherapy, which I think is really interesting, as well as gender issues, as well as pharmacogenetic genomics, I can't say it, but anyway, you'll see it when we get there. So anyway, the holistic approach to pharmacotherapy, all patients, as we know, do respond differently to the same medications. And some of you, one of you in your discussions have already mentioned that the response is often influenced by psychological, cultural, and social issues. And basically, there's also differences in our genetics, as well as their expression of our genetics. It's important to recognize that each individual, we must look at the holistic approach to pharmacology, and it leads to a complete consideration of all factors in the disease process, as well as how effective and successful pharmacotherapy is. And that extends beyond the Western approach to medicine, and we need to always consider that. So the human integrated pyramid model categorizes the functional environment in which a person exists. And I'm sure you've all looked at this before, but it's an interdependent and interrelated forming a basis of a holistic approach to care. So we're going to look at that, in that basically the underpinning is the psychological, social, and spiritual dimension, then the cultural and ethnic perspectives, the community and environmental factors, the genetic predisposition, our gender determinant, and our age corollaries. So all of these form that human integrated pyramid care model, and basically that's how we respond to the medications we're on as well. So patients are integrated human beings, both psychologically, socially, and spiritually. And all of these dimensions actually affect our illness and our performance preferences to treatment. It reflects how we actually individually act as a patient and our patient needs. And the patient history is an important tool in gathering the information and how we will react to some of the drugs that we are put on. So the psychosocial factors, of course, are developmental needs, environmental, life transitions. You can read all of these, you know them yourself, but they're really the determinants of life, that you actually think about basically all of the determinants of basically our social determinants. When you think of financial resources and our living conditions, what basically are how we're educated, how we're supported by our family, our cognitive functioning, our physical conditioning, all of these things are such huge impact on our psychosocial factors. Our spiritual considerations are also very important, basically finding fulfillment in life through social relationships, finding peace of mind, enjoying life, overlap with our psychosocial and our spiritual support when death is imminent. Also creating a positive attitude toward pharmacotherapy, and our expectations of improved health can be beneficial impact on the outcome. So remember, you all know this as well, but some people really don't have a positive attitude about what drugs can do, and also don't have a positive attitude about what the actual medical field can actually do for you as well. So keeping that in mind, how the actual health and healing will affect you. When you think about how some people, very thought of going into hospital, they are consider that they will, that's just, they're going to die. If they go to hospital, that's death for them. And so if that's the way they feel, it really usually creates a very negative environment for them. And actually they do worse. So it's all about really how they believe and how they think about the situation. So we have to be very mindful of that as well. Ethnicity really refers to the group of our common history and similar genetic heritage. The culture also refers to our set of beliefs and values and rituals and customs of a shared group. They often overlap between ethnicity and culture, and they can be used interchangeably. But again, they also do have some very great similarities and can very much influence how we react to the pharmacology as well. So as a nurse, we need to bring our different our awareness of that different cultural expectations into the relationship. We need to be aware of the patient's perspective, and we need to be open and try to understand how that culture is influencing that particular patient, and that diversity does exist between cultures and within cultures as well. So ethnicity has a huge impact on pharmacotherapy. And so, for example, diet. Diet can impact the drugs that you take, and in particularly how they're absorbed. Alternate therapies have a big impact as well, and especially when we think of traditional medications that people take, they can have an impact on the drugs that are given that are given for some basic medication or basic illnesses. Does anybody have any experience with any alternate therapies that are given for particular illnesses? Chronic illnesses, for example. Do you have any examples that you know of that people use?
Reiki?
What's that?
Is that what you're asking for? Like alternative therapies outside of the Western?
Yes.
So Reiki is a source of healing energy. It's a touch therapy. They actually have some documentations on surgeries.
Good.
Reiki is performed on the patient before surgery. Excellent. And there's evidence to show that it works in their favor for healing and everything.
And for what culture is that?
Reiki, I'm not really sure. I think it's I really don't know, to tell you the God's honest truth.
I don't know if it's a cultural thing, is it?
It's not a cultural thing, but I think it began in Japan. I think so. There's different branches.
Okay.
So I think it is, but don't quote me.
Yeah. So, and anyone else have any experience with any alternate healing or?
Acupuncture is another one.
Oh, right. For sure. I'm a great believer in acupuncture, I tell you.
Yeah.
I use acupuncture before medicine any day. Certainly with our Aboriginal communities.
I was just going to say, yeah, they go out into the forest and get their mushrooms and whatever else, right?
Yeah, exactly. Yeah. And they, they have the medicine bag. Mm-hmm. Many of them will come into the hospital, and if they forget their medicine bag, like they just won't have have the surgery. I mean, they feel so like at risk, truly at risk, and or they'll have their medicine man or their medicine healer there. You know, they have smudging and all of that. And certainly here in Barrie, we certainly facilitate, even though smoking is not allowed, we do have a room at the hospital for smudging ceremonies and that sort of stuff, because it is so important to them as a healing road, you know, like basically it's something that they need so much, you know, so it, and then the power of laying on of hands is another really strong cultural thing for basically for our Spanish or our I have a daughter-in-law from Bolivia, and it's a really a strong thing in their culture. But,
would that be the same sort of thing as putting a baby like directly on your chest when you just have it?
well, that it could be, but no, it's for them. It's when there's if someone has an illness, like it's basically literally laying on of hands in order to take away the evil spirits type of thing.
All right.
Yeah, it's quite. It's it's quite. I think sometimes it's very effective, you know.
Yeah.
It's quite interesting, you know.
Yeah, sure.
But anyway, but these things are, you know, people are so have such a strong belief and strong in it. You know, if you stand in the way of them receiving that care, it actually interferes with their wellness. Like it's
would,
and it's up until now. I could say that in Barrie, for example, it you know, for example, for our Aboriginal community, we used to actually prevent them from having smudging ceremonies, which was just ridiculous. Like anyway, we don't want to go there, but we did.
That's okay. You're passionate. That's good.
Anyway, so then the other thing is ethnicity. There are significant genetic differences. There is DNA sequencing that leads to that is actually discovered that different ethnic groups have metabolic enzymes that actually cause some drugs to not affect you in the same way. And so they have quite a significant impact on how drugs will affect you. And so you may or may not be aware of that, but if you belong to certain groups, you will learn that. And so basically then there's other things such as the community and how it, you know, community composition, and certainly socioeconomic and education. That's what I said, that's sort of the you know, the different things. But the one thing that access to care is a huge barrier. And so that things that we wouldn't think of, but, you know, like literacy, health literacy is actually a significant impact on how individuals actually, their health and wellness. And you'd say, well, why would literacy actually interfere with your health and wellness? But it truly is their ability. It's not that their individual has less smarts. It's because they don't have the understanding of what the drug is for, and they have not been taught, and people don't take the time to actually teach it in a way in which they can understand it. So perhaps it's a second language issue. And so therefore the individual has poor compliance, and therefore they do not take the drug properly. And therefore, it's a huge issue that we don't take the time to teach the individual why the drug is so important, and therefore the patient is not compliant, not because they don't want to be, but because they simply don't have the literacy skills to understand why they should be taking the drug properly. So the burden comes back on the healthcare provider. So it is another issue that we have not paid a lot of attention to it, unfortunately, as a healthcare provider. And then the genetic influences. So here's some of the issues that in the human race, 99.8% of us have basically our DNA is identical, but the remaining 0.2% differences actually along the ethnic line. So the polymorphism, the mutation part of it, actually causes some significant changes in drug metabolism, which is really quite interesting, and a lot of research is going on. So for example, acetyltransferase, which is metabolism of isocyanase, which is a tuberculosis drug. And so Caucasians and African Americans, we are slow acetylators of that drug. And so we can reach toxic levels relatively quickly. Thus, we require really low doses, but Japanese are rapid acetylators. And so they actually have to have really frequent dosing because they actually metabolize the drug so quickly that they actually have to have a different dose altogether. And that's all because of that 0.2% genetic difference between Japanese race and Caucasian and African Americans. And who knew, right? And like that's only been discovered, recently, that in fact, in giving that medication, it wasn't working for the Japanese population, but it was working for African American and Caucasians. And then they discovered that it basically, the actual treatment dose had to be increased for Japanese because they actually were metabolizing it so fast. Isn't that interesting? And that's happening for a lot of drugs. So here's a list of drugs that actually are different. So again, the Scandinavians, Jews, North Africa, Caucasians were slow, and the Japanese are fast. So this is examples of some of the drugs. Like, for example, this is a heart drug. Caffeine is another one. And this this is all another heart drug here. And then this poor metabolism by Asians and Africans. And so this is a heart drug. This is codeine and morphine. So basically, these are poor metabolizers. So the actual metabolism of that particular drug is a different rate. And this is a high blood. These two are blood pressure drugs. All three of these actually. These are beta blockers. So I just got to take a drink here. I'm going to cough in your ears. And then then for this particular one here is poor metabolism by Asians and Africans. This is so the diazepam and barbiturates and warfarin. They're all different. So it's interesting that 0.2%. So you have, so basically the dosing for these populations have to be different based on your genetics. Kind of interesting, isn't it? I think it is anyway. So pharmacogenetics is the study of genetic variations that alter the patient's responses to medication. So that's something you need to know. And pharmacogenomics is a network of genes that governs a person's response to drug therapy. So that's two definitions. And through improved genetic sequencing, techniques are being, is possible to identify that genetic polymorphism in each individual and customize treatments focusing on your genetic profile. The ultimate goal is to improve the safety and efficacy of drug therapy through genetic guided treatment. So basically, they're working on that as we go. Well-established differences in patterns in diseases already we know is different between males and females. We know that the cardiac problem is historically a man's disease, and Alzheimer's, unfortunately, is a female disease. It's 1.5 to 3 times more common in women. Isn't that a treat? And then gene expression differs between males and females as well. And other gender differences, current research recognizes gender differences in drug response and also factors that influence response is body composition, fat compared to muscle ratios can affect how drugs react, and cerebral blood flow variations can be affected the distribution of analgesics to the central nervous system. So how fast your blood flows to your brain will affect how analgesics go to your central nervous system. And women tend to pay more attention to changes in how we seek health care than men, and that's well proven. And the effect of adherence to medication regimes, antihypertensive drugs produce impotence in men and cause gynecomastia, which is enlarged breasts, and abrupt withdrawal from antihypertensive drugs causes strokes. Estrogen in oral contraceptives causes thromboembolic disorders in women, and we all know that too. And that's the end of that particular one. But those are important pieces of information. And why is that important to you? These are health teaching information that you should know as you're giving medications to people in general. Okay, so these are just good to know pieces of information. And that's something you carry with you as you go through giving medications over the years. Okay. And then I'm not going to go through this one on the lifespan, because it's this little article here has been, as I have written it out for you in a document, and it's a little, well, probably the other ones just is, but I just want you to see the format of this. So pediatrics, and the four things that I want to really emphasize, and Alicia did a really good job on her discussion board of talking about the 4 phases of metabolism, or of pharmacokinetics. So pharmacokinetics is the process in which the drugs are processed through your body. And the 4 stages are absorption, distribution, metabolism, and excretion. So that is really important for you guys to remember. And so in pediatrics, it's broken it down into what are the factors affecting absorption, distribution, metabolism, and excretion in children, and then the 4 factors in the geriatric population. And so this is an article I really want you to read and pay attention to it, because basically what are the factors that affect pediatrics? And so basically the 2 important factors that affect pediatrics when you're prescribing an oral medication is that the gastric pH, and basically there's an increase in their gastric pH and a delayed gastric emptying. And the decrease in the rate of emptying means that the drug remains in the stomach for an extended period of time. And as a result, drugs in the stomach are absorbed sooner than those that are absorbed in the intestine. And that's what makes them different from adults, right? And weak acids tend to have a slower absorption rate, and low gastric acids have a tendency to increase the absorption rate of acid labile drugs. So basically, they are not the same as adults. And so when you look at how an adult absorbs, basically that first phase of the pharmacokinetics and the process in which drugs are moved through the body is in that stomach area. And so basically there is a difference in the gastric, the amount of acid in the stomach. Okay, so and then there's also minimal blood flow through the skeletal muscle of an infant. And so basically if you administer an intramuscular or a subcutaneous route, it's absorbed slower, whereas in an adult, it's absorbed faster, right? And so those are some of the differences. And then the distribution, of course, the proportion of water to fat is different. And so just read that and understand that part for the infant. And then look at the geriatrics and figure out and see the difference with them, because the difference with them is that because of the aging system, they also have some differences. And again, the absorption is different. It's decreased gastric motility, so that they too, the drug stays in the GI tract longer. And as an increased risk of a GI adverse effect, the GI pH increases and the drugs require more acid to absorb, and it takes longer to be effective. And so the same drug that you would give an adult, is not as effective in a senior. And the distribution again, and then for excretion, the problem is that the kidneys and the liver doesn't work as well. So and then also there's an article part here on how do you administer to the different age groups, and the dosing, what you need to take into consideration. And so this is like all you need to know about adults and children on dosing. And it's a short little article, but it really is good to know. And again, it's sort of one of those Cole's notes about what to take forward from now on as you are treating adults and geriatrics, and just sort of, it's the hallmark of this is what I need to think about whenever I am giving medications to children or giving medications to seniors. Okay, so that's what I wanted you to pay it just to, and this last part is just about what community nurses need to do in order to teach families and so on to look after themselves, sort of thing. But up until this point, it's really important for you to read that. Okay, so I really wanted to draw your attention physically to that particular one, because it's good information, and it's not laid out just exactly like that in the PowerPoint. It's got all that information there, but I like the way this is put together. At least I put it together that way, and I think it's good. Anyway, so that's what that is about, and the PowerPoint is just like that, but it's a little different. So I'm not going to keep you all night. I'm just wanted to draw your attention to that, and then ask you if you have any burning questions. Does anybody have any burning questions? I will post some cheat sheets, they're called, in order to prepare you for your exam. But it's easy to find the answers to the exam because they're on the PowerPoints. And people like Sabrina usually answer the exam within 15 minutes of starting it. So I always think to myself afterwards, oh, I didn't make it hard enough. But you can see here. Oh yeah, the other thing here that is good here though on the PowerPoints is this. What happens if if you're pregnant, and what kind of drugs you should be careful of. So these are the categories of drugs that when you're pregnant, and which ones you should stay away from. So there's category A, B, C, D, X, and N, and why you shouldn't take these categories of drugs. So be aware of these pregnancy categories. And these talk about A and B, consider them safe. C is, there has been some studies, they should be avoided if possible. D and X, don't take at all. N, there's been no studies. But, and so there's some interesting stuff on that. But basically, there's a lot of other stuff about breastfeeding and that sort of stuff. It's not. And then these are the select drugs that are compatible with breastfeeding, kind of interesting. But these are things you would look up in your book. And then there's a lot of stuff. This book is really big on breastfeeding, just so you know. It goes on and on and on. What do you feed? What do you give them? That's why I like the other one better. Anyway. So you go through this, but and then and then there was this piece on how do you get older people to adhere to their medication, and we already talked about this, and people have posted about how to do this as well. So, okay. Questions, comments? Are you okay to go?
Good to go.
Good.
We're good to go.
All right. Well,
So I guess it's not a question about like the content. Just are we having a weekly meeting? Because I didn't know until I got the notification on my phone that there was one today.
no, I'm not planning it. I usually it depends on whether I have a message to give you, and
Okay.
you don't have to be here. What I do if you're not here, I would just post. I will do a little voiceover thing or a screencast, and then you can look at the video.
I know. I just feel like I like to attend, but I just didn't know about it until I got them on my phone. I'm like, oh, okay,
Yeah,
I'll attend it. But okay.
I don't like to take your time unnecessarily. No.
Okay. That's all I had. I was just wondering about that.
Yeah. So no, it's not intended that we have weekly meetings for sure, but I just wanted to get you to look at that one little article there and have a little talk about that the genetic stuff. Okay.
Yep.
Okay. That's it.
I'm good.
That's it, kids.
Okay.
We'll
Alright.
talk. So we won't have one next week because you're going to be writing your test, and you'll be over. And then next week is a heavier week, so we'll probably have one in 2 weeks. Oh yeah, and I'm moving, and so next week is the 27th, and then the week after is a holiday. So sometime after the probably near the, I don't know how my reception's going to be. That's what I'm concerned about. So I have to the supply. It's a new house, and the provider has not been in and set up my stuff yet. So I'll have to get a hold of you. So keep your eyes open for me, and I'll be sending you messages about what you'll have screencasts, but you may not get me live until the provider gets in and gets me connected.
Okay.
I'm in the boonies. I'm going to be like Sabrina, somewhere off in the woods.
Yep. Pretty much.
Beavers. Okay,
Cool.
we'll talk.
Okay.
We discussed in the case study because it says that's next week. Or introduction to case.
Oh yeah, the introduction. Well, I'll have it on screencast,
Okay.
and you can ask all the questions you want. Don't worry.
Okay.
You can connect. We'll connect, even if it's by phone. It's always teleconference. I can do it that way. Okay.
Yep.
Okay. Bye.
Thank you. Thank you.
Bye. Have a good night.
Good
Thank
night.
you.
Okay. Take care.
Bye.
Joshua? Josh?
Yep. Where's my mouse?